Hello again, everybody. I'm going to talk now on combination therapy, and I'm sorry that I had to do this recording in advance, but I had to run out for a family event. In terms of the discussion, I know that Jafar and I are philosophically aligned on this topic, so I'm sure that he can help lead any discussion after the talk is done. So we're going to talk about combination therapy, and by that I mean combining the use of liquids with either coils and plugs. And so my case is actually pretty simple. We're looking at a 64-year-old guy who presented with upper GI bleeding. He underwent an endoscopy which showed duodenal blood, but no clear source of bleeding. So he presented for angiography with probable embolization for more definitive therapy of this bleeding. We did our angiogram. I think you can see here what most people tend to see during these cases, and that's no evidence of active bleeding. You can see that on early and delayed phase imaging. So we got more selective into the GDA. Again, saw nothing of consequence. We got a little further distal into the GDA. Again, didn't see anything that we were overly concerned of. So now the question is, what are we really trying to do here with the GDA embolization? I think that most of us would look at a case like this and fill that space with coils with the goal of preventing additional bleeding in the future. But I think there might be a role for liquids here as well. The fear here is that the liquids may run away from us distally and potentially create some non-target embolization within those terminal branches of the GDA. So in a case like this, we often turn to placing proximal coils at the origins of the terminal branches and then filling the rest of the space with a liquid embolic agent. I think there's real advantage here. It's a great space filler. It can even seep into some of those side branches and potentially create an even more definitive embolization to prevent that future bleeding. And here's what the final picture might look like. So what is the rationale behind doing something like this? Well, I think it lies in the concept of packing density. So if you take a typical GDA, perhaps in this case a 5 millimeter GDA targeting a 5 centimeter length, that's about 1,000 cubic millimeters. And even if we were looking to target 24% of that space, that's still 235 cubic millimeters. The available coils that we have range in volume from about 8 or 9 cubic millimeters up to 60 cubic millimeters. And even if you're just seeking to get to that 24% mark, it's still a lot of coils to use. Keep in mind that 1 ml of a liquid agent is equivalent to 1,000 cubic millimeters, which means we can use 1 ml of a liquid and get to 100% of the vessel volume that we're targeting. So if you like this idea, there are other potential applications of this. Here's a patient who had some splenic trauma with a significant laceration. We were called in to do a proximal splenic embolization. Here's our angiogram. We obviously don't see much of consequence, maybe a little bit of distal staining, but nothing that we would chase distally. So we opted for a proximal embolization here. We put some coils in the mid-splenic artery and then used lava to backfill some of that proximal splenic artery to really fill the space and get a more definitive proximal embolization. And when we're done, you can see the proximal occlusion as well as the distal opacification via short gastric collaterals. Again, you can use that packing density argument. Here's an 8 millimeter splenic artery. Let's call it a 3 centimeter length for about 1,500 cubic millimeters. Again, that 24% packing density target might be about 360 cubic millimeters. Again, you need a lot of coils to fill that space, even the 24% space, but 1,000 cubic millimeters per ml, again, gives you 67% of the total volume of that splenic artery space, and certainly way exceeds that 24% packing density target. Here's another splenic injury case. You can see that focus of arterial bleeding within the spleen. We looked at that, went distal, and found an AV fistula. In this particular case, we used Obsidio to address the small vessels leading into the AV fistula, but then decided to do a proximal embolization on the way out. In this case, we had a microcatheter in place. We used an Azure plug, but still saw some flow through the plug. We waited for a little bit of time, still saw it, and then realized that we had some Obsidio left in our syringe, and so we used that to fill the proximal space and get that definitive embolization that we're looking for. And finally, I just want to show a quick endoleak case where you can see here on the inferior aspect of the sac on these sagittal images, a focus of contrast opacification on the CTA. You can also see the IMA sitting right there. So we approached this with a translumbar access and moved our catheter all the way to the antero-inferior aspect of the sac where we saw the inferior mesenteric artery. we were able to access the inferior mesenteric artery and subsequently put a coil or two right near the origin of the IMA and then backfilled that space with onyx into the aneurysm sac to provide a good embolization of the endoleak. So in conclusion, I think that combination therapy definitely allows us to maximize packing density within our target vessel volume. And I think in many cases, but I'll acknowledge not in every case, you can make a very clear time-based argument and cost-based argument which favors the use of liquids in combination with either coils or a plug. Thanks.